Good day, everyone. I am Abigail Sade, and today I am going to talk about chronic renal failure.
The flow of the discussion would be as follows. First, I am going to talk about the pathophysiology, clinical manifestations, and the complications of the disease. And then next, the diagnostic tests and laboratory procedures. Afterwards, I will proceed to the treatment modalities, medical management, nursing management, and lastly, the prognosis. First, what is chronic renal failure? It is when a patient has sustained enough kidney damage to require renal replacement therapy on a permanent basis. The patient has moved into the fifth or final stage of CKD and is also referred to as chronic renal failure or end-stage renal disease. It is a progressive deterioration of renal function in a long period of time, which ends fatally in the buildup of waste, water, and electrolyte imbalances in the body and its complications unless dialysis or a kidney transplantation is performed. Next, I am going to talk about the pathophysiology, clinical manifestation, and complications. What are the risk factors of chronic renal failure? It could be due to diabetes mellitus, hypertension, autoimmune disease, older age, a family history of renal disease, previous episode of acute renal failure, or structural abnormalities of the urinary tract. So what could be the causes of chronic renal failure? It may be due to primary glomerular diseases such as glomerulonephritis, immunoglobulin A nephritis, or pyelonephritis. It could also be due to systemic diseases such as diabetes mellitus, hypertension, or post-infectious glomerulonephritis. Hereditary nephropathies could also lead to chronic renal failure, such as hereditary nephritis or polycystic kidney disease. Furthermore, vascular causes in which it could be large vessel disease such as bilateral renal artery stenosis or small vessel disease such as ischemic nephropathy and vasculitis. And lastly, obstructive causes such as bilateral kidney stones and diseases of the prostate. Moving on to the pathophysiology of chronic renal failure. First, due to the etiological factors, this would lead to the decrease in the glomerular filtration rate, in which it would cause the compensatory hypertrophy of remaining nephrons. Once this occurs, there would be a loss of excretory functions, and then as time goes by, there would be a loss of non-excretory renal functions. And then lastly, this would all proceed to the sclerosis of remaining nephrons and the total function loss. The most common causes of chronic renal failure is hypertension and diabetes mellitus. So from here on, I would focus on these two diseases to expound the pathophysiology of chronic renal failure. When a person has hypertension, this would cause arterial wall thickening, and then it would cause the lumen to become narrow. And then this would cause the decrease in oxygenated blood supply to the kidneys. Over time, the renal function to decline, in which this would decrease urea excretion and lead to urea accumulation in the blood. Once this occurs, this would be the cause of uremia, and then would have signs and symptoms such as nausea, loss of appetite, and uremic frost. Uremia also leads to uremic neuropathy, which affects central nervous system and the peripheral nervous system. Once the central nervous system is affected, there would be encephalopathy, which can cause complications such as seizures, coma, and death. There would also be symptoms such as confusion, asterexis, and paresthesia. When the peripheral nervous system is affected, there would be uremic peripheral neuropathy, in which there would be sensations of burning feet and a symptom of restless leg syndrome. Uremia also causes uremic pericarditis, in which pericardial friction rub is heard upon auscultation. And chest pain is also experienced. Furthermore, there would be also decrease in clot formation due to uremia, and then this would increase the risk for bleeding. Renal function decline also decreases potassium excretion, which would result to potassium accumulation in the blood and becomes hyperkalemia. This would result to the symptoms of paresthesia, muscle weakness, and palpitations. Renal function decline also leads to the decrease in calcitriol absorption and decrease in phosphate excretion. Focusing on phosphate excretion decrease, this would cause the phosphate accumulation in the blood and would cause hyperphosphatemia. The decrease in phosphate excretion also leads to improper conversion of calcifidiol to calcitriol, which would then on lead to the decrease in calcitriol absorption. This would cause the decrease in calcium absorption and becomes hypocalcemia, in which bones lose calcium. This would lead to the symptom of renal osteodystrophy. Furthermore, the renal function decline also increases renin secretion, which leads to hypertension, and a decrease in erythropoietin level, which would decrease the red blood cell production and would cause anemia. Moving on to diagnostic tests and laboratory procedures. The glomerular filtration rate is measured to identify the disease. The GFR and creatinine clearance decrease while serum creatinine and bun levels increase. For urine tests, creatinine clearance may be significantly decreased, which is less than 80 milliliters per minute in early failure and less than 10 milliliters per minute in ESRD. For sodium, it could be more than 40 milliequivalent per liter because kidney is not able to reabsorb sodium. For protein, high-grade proteinuria strongly indicates glomerular damage when red blood cells and casts are also present. Furthermore, renal ultrasound could also be performed. This would determine kidney size and presence of masses, cysts, or obstruction in upper urinary tract. Renal biopsy could also be done in order to examine tissue cells for histological diagnosis and may be done endoscopically. For ECG, it may be abnormal, reflecting electrolyte and acid-base imbalances. X-ray of feet, skull, spinal column, and hands are performed, which may reveal demineralization or calcifications resulting from electrolyte shifts associated with chronic renal failure. With chronic kidney disease, the kidneys don't usually fail all at once. Instead, kidney disease often progresses slowly over a period of years. To help improve the quality of care for people with kidney disease, the National Kidney Foundation created a guideline to help doctors identify each level of kidney disease. The National Kidney Foundation divided kidney disease into 5 stages. The glomerular filtration rate is the best measure of kidney function. The GFR is the number used to figure out a person's stage of kidney disease. As you can see, the normal glomerular filtration rate is greater than or equivalent to 90 milliliters per minute per 1.73 meters squared. Based on estimated glomerular filtration rate or eGFR, chronic kidney disease is classified into 5 stages, which is called G stages, and is measured in units of milliliters per minute per 1.73 squared meters. In G1, eGFR is greater than 90 and is identified as kidney damage with normal or increased GFR. In G2, eGFR is 60 to 89, in which it is mild reduction in GFR. In G3A, the eGFR is 40 to 59 and is identified as mildly to moderately decreased GFR, while in G3B, the eGFR is 30 to 44 and is identified as moderately to severely decreased GFR. In G5, the eGFR is 15 to 29 and this is severe reduction in GFR. Lastly, in G5, the GFR is less than 15, which is identified as kidney failure. For individuals with stage 5 or G5 chronic kidney disease, if they are on dialysis, added to the stage, making it G5D. Albuminuria is also added to chronic kidney disease staging, and it is identified as A stages. In A1, the albumin levels are greater than 30 and is identified as normal to mildly increased ACR. In A2, it is 30 to 299 and is identified as moderately increased ACR. While lastly, in A3, it is greater than 300, which is severely increased ACR. Using both stages, we can further identify on what stage the patient with chronic kidney disease is. In the green area, it is identified as low risk of disease progression. Once it is in the yellow area, it is moderately increased risk of disease progression. If it is in the orange area, there would be high risk of disease progression. Once the patient is identified to be in the red areas, it is in very high risk of disease progression, and this would lead to end-stage renal disease. So what are the treatment modalities of chronic renal failure, or also known as end-stage renal disease? Focusing on chronic kidney disease, in its early stages, the treatment would be controlling blood pressure and glucose level. Medications for hypertension are also done to help protect the kidneys, such as ACE inhibitors or ARBs. There would also be monitoring GFR and blood pressure regularly. Once CKD reached the advanced stages or end-stage renal disease, dialysis, kidney transplant, and diet changes are performed to manage the disease. The patient with chronic renal failure has dietary regulations to manage the disease, and this includes careful regulation of protein intake, fluid intake to balance fluid losses, sodium intake to balance sodium losses, and some restriction of potassium. At the same time, adequate caloric intake and vitamin supplementation must be ensured. Furthermore, when the patient has uremia, low-protein diet is done. Urea is a waste product of protein breakdown. However, patient needs some protein to prevent muscle wasting. Protein must be of high biologic value such as dairy products, eggs, and meat. For hyperkalemia, there is restriction on potassium-rich foods such as potatoes, avocados, strawberries, tomatoes, spinach, oranges, and bananas. For hyperphosphatemia, diet is low in phosphate. Foods that are phosphate are restricted, such as poultry, fish, dairy, nuts, sodas, and oatmeal. Maintenance dialysis or kidney transplantation are done when symptoms can no longer be controlled with conservative treatment. The patient with increasing symptoms of renal failure is referred to a dialysis and transplantation center early in the course of progressive renal disease. Dialysis is usually initiated when the patient cannot maintain a reasonable lifestyle with conservative treatment. Moving towards the medical management of this disease. The pharmacologic therapy for chronic renal failure are calcium and phosphorus binders to treat hyperphosphatemia and hypocalcemia. Also, antihypertensive and cardiovascular agents such as digoxin and dobutamine to manage hypertension. Anti-seizure agents are also given, such as intravenous diazepam or phenytoin, that are used for seizures. Erythropoietin is given to treat anemia that is associated with end-stage renal disease. Next are the nursing managements. The nursing diagnosis for chronic renal failure are as follows. Excess fluid volume related to decreased urine output, dietary excesses, and retention of sodium and water. Imbalanced nutrition less than body requirements related to anorexia, nausea, vomiting, dietary restrictions, and altered oral mucous membranes. Next, activity intolerance related to fatigue, anemia, retention of waste products, and dialysis procedure. There's also risk for situational low self-esteem related to dependency, role changes, changes in body image, and change in sexual function. These are the nursing interventions that are done. Assess fluid status and identify potential sources of imbalance. Implement a dietary program to ensure proper nutritional intake within the limits of the treatment regimen. Then promote positive feelings by encouraging increased self-care and greater independence. Also promote intake of high biologic value protein foods such as eggs, dairy products, and meat. Alter schedule of medications so that they are not given immediately before meals, and encourage alternating activity with rest. This is the final discussion of this disease, its prognosis. End-stage renal failure, or also known as end-stage renal disease, is the final, permanent stage of chronic kidney disease, where kidney function has declined to the point that the kidney can no longer function on their own. A patient with end-stage renal failure must receive dialysis or kidney transplantation in order to survive for more than a few weeks. The overall prognosis of untreated ESRD is poor. Most persons with ESRD eventually die from complications of CVD, infection, or, if dialysis is not provided, progressive uremia.
Thank you for listening until the end of the discussion, and I hope you've learned a lot about chronic renal failure.